start. Thank you very much, Bansi, for inviting me to speak on this grand platform, and also congratulations for doing such a good program. The topic that I'm going to discuss today on sulfonylurea is my original paper and was accepted for oral presentation at International Congress of Endocrinology in 2021 February, and I presented it virtually. Now, the topic of my lecture is effectiveness and durability of extended release glycoside in the treatment of type 2 diabetes, a real world perspective. This is the place where I work. It is Apollo Gleneagles Hospital, Kolkata, and I had the pleasure of many of you coming to my program here. Before I start, I think I need to give some preliminaries. That glycoside, the modern sulfonylurea, is slightly different from the older generation, because glycoside binding, I'm talking of the mode of action, is that it attaches to the sulfonylurea receptor complex on the SUR1 and it bypasses the EPAC. So what is the consequence of this? The consequence is that it is reversibly attached, it has got a pulsatile insulin release, and it does not affect the KATP channel in the cardiac myocyte. It is on the sarcolemmal KATP. Therefore, it does not affect the ischemic preconditioning. It has chances of less hypoglycemia. So that is the mode of action I'm showing you. The same for glimepiride again. Another modern sulfonylurea. It does not affect the KATP channel in the cardiac myocyte, but on the sarcolemmal KATP. Therefore, these modern sulfonylureas are much better and different from the older generation of sulfonylureas. Now, there are many myths attached to this: the hypoglycemia, weight gain, beta cell exhaustion, durability of glycemic control, and cardiovascular safety. I would like to context these myths with evidence. If you look at the 2020 ADA ESD guideline, you can see that sulfonylurea has been kept under the heading cost. And of course, it's other places also, if you can see here, but much down the ladder. I believe it's an oversimplification of the efficacy and durability of this molecule, because the same body puts glycoside as a highly efficacious molecule in its chart. If you talk about the hypoglycemia and weight gain, then you know the gold standard of diabetes care is, of course, insulin, and they are also not bereft of these virtues, ironically speaking. Now, let us say that weight neutrality. We often talk about sulfonylurea and weight gain. Remember that weight gain is not the property of an isolated molecule. A lot depends upon the diet, the glycemic index, the glycemic load, the calorie distribution, the compensating of minimal hypoglycemia and overeating, lack of exercise, calorie expenditure, and then of course comes the molecule. Advanced study is something which were 8 years average intake and then 6 years, so 14 years of diabetes did not show an weight gain. I think this is an important issue to remember, that glycoside was given to 91% of patients in advanced study, and then what we found, and 40% had insulin at the end of the study. In weight gain in metformin and glimepiride. So this is the preamble I'm trying to do for sulfonylurea modern ones. Now, beta cell exhaustion is a very tempting hypothesis, almost said in a sweeping statement in many conferences. Remember that way back, diabetes may itself cause beta cell decline. This is a very important statement. Then, of course, you more pedantic one would like to know, do we have any laboratory evidence to that? This is the laboratory evidence, but the beta cell line, the pancreatic beta cell line, was exposed along with glycoside with other molecules with a comparator to see whether it causes excess production of reactive oxygen species or beta cell apoptosis. And what they found, that if you look at the comparator here, and this is the glycoside, So, if not more, definitely, gliclazide did not cause, rather it benefited the experimental study where it did not show increased apoptosis or increased reactive oxygen species production. So beta cell exhaustion with SUs, again, as I said in advance, 11,000 patients, 14 years, and then beta cell exhaustion, I think, is a myth rather than a reality. Now, CV safety is another issue that we keep talking about, but I think we shouldn't throw the baby with the bathwater. Now we have got any number of meta-analysis. This is one you can see where gliclazide is on the forest scatter on the better part. So again, the CV mortality, you can see gliclazide is quite safe. And if you look at the Braunwald's textbook of cardiology, then also you can see that gliclazide has entered and it does not affect ischemic preconditioning and has been said is non-inferior to placebo in terms of cardiac safety. So let us for 1 minute forget that this modern sulfonylureas are same as the first generation. So another meta-analysis for the cardiovascular safety, because this is the brass tacks of the molecule, and that meta-analysis in the European Heart Journal again showed that sulfonylurea was not associated with any significant difference in incidence of MI with respect to comparative. If you look at the real world evidence, then also there is, of course, a gliclazide from the real world evidence in UK, and it compared itself with sitagliptin, and it shows 51% more efficacious. Therefore, with these backup evidence on my presentation, I want to present my study and contest the age-old myth against modern sulfonylurea. Now, modern sulfonylurea, including extended gliclazide, are acceptable standard of care in the management of diabetes. And that is my hypothesis. Now, my objective was to assess the control rates and periods until the initiation of insulin from the onset of diabetes. So my primary goal was to see the durability. What I mean that once the patient was diagnosed with diabetes and they were put on gliclazide, how many years it took to start insulin. So I'm talking of the durability of the molecule. And also secondarily, we looked at the efficacy. We looked at the hypoglycemia and we looked at the weight gain. Remember, this is very important because in this study, we are looking at durability. What we are trying to say that if you say that if you get sulfonylurea on board, especially the modern ones, you are going to increase apoptosis, I believe is a myth. So let's see what my study found. My aim was to assess durability, second efficacy, third weight change, and hypoglycemia, as I mentioned already. Now, what is the method? What we did is to maintain homogeneity, we recruited 300 patients who are regularly following up with me in our clinic to maintain a homogeneous character of the cohort. And we took the patients who are already 5 years of diabetes. So some patients who are already on 5 years of diabetes, they are continuously following up with us in our clinic to maintain the homogeneity in lifestyle advice as well. And what we found is that we had 159 male, 141 female, and then evaluate the patient under a retrospective longitudinal analysis. The study was conducted in 2018-19 in a dedicated institutional diabetes care clinic in our multi-specialty hospital, Apollo Clinical Hospital. The patient with the duration of diabetes was more than 5 years, as I said. And what I found interesting was we had patients even over 20 years on this regimen, gliclazide plus standard of care. And they were still on the oral hypoglycemic agent and not on insulin. Structured patient education and lifestyle management was provided during each follow-up visit. And we did a descriptive statistics for analysis. These are the results of our study. We had a mean age of 55.14 years. So the patient we included were probably the typical OPD patients, slightly older because we are following them up. The mean HbA1c was 7.1%, which is almost near to the target of ADA guidelines. So we had 82% of patients who achieve target range of HbA1c less than 7%. So 18.7% patient had diabetes for more than 20 years. I think this is interesting to note. And not necessarily all of them were on insulin. The mean duration of treatment of the regimen of glycoside, extended release plus metformin, was 12.81, almost 13 years, plus minus 6. What I'm trying to say is those patients who were diabetic and who were put continuously on glycoside, the average duration was 13 years before they needed insulin. But remember, there are plus 6, so it is something around 19 years without insulin. And of course, there are a few who were 5 to 10 years and needed insulin. But we had an average of 13 years. Maybe some credit you would give to the standard of care that we have developed now. But this is an evidence that if it was acting as a hurdle, if the modern sulfonylurea was a hurdle to the durability, then it should have happened much earlier. Only 1% patient reported episodes of confirmed hypoglycemia, but were self-managed. Again, if you contest this data with the advanced study where it was only 1.5%, and of course, the reason that there is slightly more hypoglycemia in the advanced study is because they targeted HbA1c of 6.5% in the well, so you'd like to know exact distribution of the data that we found out. So you can see we had the sex 159 male and 141 female. Less than 25 BMI was 150. I want to draw your attention that we had 50% of patients who had a BMI of less than 25. So this is interesting because this is what our population demography looks like in our clinic. But of course, I'm not saying that they didn't have a central obesity. 26 to 30 was 124, 31 to 34 was 19 patients, 35 to 40 BMI was 5, and over 40 BMI was 2. And duration of diabetes, we had 5 to 9 years, 1/3 of the patient, and 2/3 of the patient had diabetes from 10 years onwards. So therefore, 87 patients, 54, 56, and 49, and 56 patients. So we had a huge number of patients who had far more than 10 years of diabetes duration. Insulin requirement, nobody needed below 5, that's why we recruited them. 5 to 9 years, only 4 patients. 0 to 14 years, we had 18, that includes the 4. Remember, so I'm including as I go. 0 to 14 years, we had 18, 0 to 19 years, 37, and of course, more than 20 years, 49, all inclusive. So this is the data, weight is used for BMI group. I also, so you must remember that we have been using the standard practice. Some weight gain was also due to some patients were on pioglitazone. Therefore, this is the description of our finding. If you look at the pie chart for a better understanding, 6.3%, 49 patients in due course required insulin. So we had 16.3% of patients who needed insulin. The number of patients, the BMI, as I said, was 150 patients below 25, which is, of course, very much a clinical picture. The number of patients with duration of diabetes, again, I said 1/3 was 5 to 9 years, but rest was longer duration, 2/3. So you cannot say that I included only the younger patients to see that. Insulin initiation was started at more than HbA1c. The fundamental question you would ask me, when did I start insulin? Of course, if the patient failed to come under control and HbA1c more than 8%, we start. If you look at, you see 50% has got a BMI less than 25. And if you look at the duration of diabetes, then also you understand that there are a huge number of patients, 2/3 of them were beyond 10 years. So what is the conclusion? We observed a sustained glucose lowering attributed to glycoside-based approach, demonstrated by majority of patients, which enabled to postpone insulin initiation despite a long duration of diabetes. This is fundamental. We often in our clinic try to advise and take out the sulfonylurea. You can do, of course, in your wisdom with individualized patient. But what I am trying to get home the message that this is a study that tells you that we can continue with glycoside and even reduces the dose of insulin requirement. Overall, the patient achieved a glycemic level close to the target of 7% and below. Our findings support sustained glycemic control for durability with potential to postpone insulin initiation attributed to extended release glycoside, a modern sulfonylurea. To sum up, if you are still not convinced, cost is also very important. And this was my bibliography. And thank you for listening to me.